Trichotillomania, commonly known as hair pulling disorder, represents one of the most misunderstood and stigmatized mental health conditions in contemporary psychology. This complex behavioral disorder affects millions of individuals worldwide, transcending age, gender, and socioeconomic boundaries while leaving behind a trail of physical and emotional consequences that extend far beyond the visible symptoms. The condition manifests as an irresistible urge to pull out one's own hair, typically from the scalp, eyebrows, eyelashes, or other body areas, creating noticeable bald patches and causing significant distress in the individual's daily functioning. The etymology of trichotillomania derives from three Greek words: tricho, meaning hair; tillo, meaning to pull or pluck; and mania, referring to an excessive urge or compulsion. This linguistic breakdown perfectly encapsulates the essence of the disorder, which was first formally described in medical literature during the late 19th century by French dermatologist François-Henri Halepeau. Despite its historical recognition, trichotillomania remained largely overlooked and misunderstood until the latter half of the 20th century, when mental health professionals began recognizing it as a legitimate psychiatric condition requiring specialized treatment approaches. The prevalence of trichotillomania varies significantly across different populations, with research suggesting that approximately 1 to 2% of the general population experiences this condition at some point in their lives. However, many experts believe these statistics represent a significant underestimation due to the secretive nature of the disorder and the shame associated with hair-pulling behaviors. The condition typically manifests during adolescence, with peak onset occurring between ages 12 and 14, though it can develop at any stage of life, from early childhood through adulthood. Interestingly, trichotillomania demonstrates a strong gender bias, with females being affected approximately 4 times more frequently than males, though this disparity may partially reflect reporting differences rather than actual prevalence rates. The psychological mechanisms underlying trichotillomania remain complex and multifaceted, involving intricate interactions between neurobiological, psychological, and environmental factors. Current research suggests that the disorder may stem from abnormalities in brain circuits responsible for impulse control, habit formation, and reward processing. Neuroimaging studies have revealed altered activity in regions such as the anterior cingulate cortex, orbitofrontal cortex, and striatum, areas crucial for executive functioning and behavioral regulation. Additionally, genetic factors appear to play a significant role, with family studies indicating higher rates of trichotillomania and related conditions among relatives of affected individuals. The phenomenology of trichotillomania encompasses a wide spectrum of behaviors and experiences that can vary dramatically between individuals. Some people engage in automatic hair pulling, occurring without conscious awareness during periods of boredom, stress, or while engaged in sedentary activities such as reading, watching television, or working at computers. Others experience focused hair pulling, characterized by deliberate, intentional behaviors often preceded by specific thoughts, emotions, or sensations. Many individuals report experiencing a building tension or urge before pulling, followed by temporary relief or gratification afterward, creating a self-reinforcing cycle that becomes increasingly difficult to break. The physical consequences of trichotillomania extend beyond cosmetic concerns, potentially leading to serious medical complications. Chronic hair pulling can result in permanent hair loss, scarring, and skin infections at affected sites. In severe cases, individuals may develop trichobezoars, or hair balls, in their digestive system if they habitually ingest pulled hair, a behavior known as trichophagia. These hairballs can cause intestinal blockages requiring surgical intervention. Additionally, the repetitive nature of hair pulling can lead to carpal tunnel syndrome, tendinitis, and other musculoskeletal problems affecting the hands and arms. The psychological impact of trichotillomania often proves more devastating than the physical consequences, with affected individuals frequently experiencing profound shame, embarrassment, and social isolation. The visible nature of hair loss forces many people to develop elaborate concealment strategies, including wearing wigs, hats, or scarves, using makeup to camouflage bald spots, or avoiding social situations altogether. These behaviors can significantly impair academic performance, occupational functioning, and interpersonal relationships, creating a vicious cycle where increased stress and isolation further exacerbate hair-pulling behaviors. Diagnosis of trichotillomania requires careful clinical assessment by qualified mental health professionals, as the condition shares features with other disorders such as obsessive-compulsive disorder, body dysmorphic disorder, and various impulse control disorders. The diagnostic criteria include recurrent hair pulling resulting in noticeable hair loss, repeated attempts to decrease or stop the behavior, and significant distress or functional impairment. Clinicians must also rule out other medical conditions that might cause hair loss, such as alopecia areata, thyroid disorders, or dermatological conditions. Treatment approaches for trichotillomania have evolved significantly over the past several decades, with evidence-based interventions showing promising results for many individuals. Cognitive behavioral therapy, particularly acceptance and commitment therapy and habit reversal training, has demonstrated effectiveness in reducing hair-pulling behaviors and improving quality of life. These therapeutic approaches focus on increasing awareness of pulling behaviors, developing alternative coping strategies, and addressing underlying emotional triggers. Some individuals may benefit from pharmacological interventions, including selective serotonin reuptake inhibitors or N-acetylcysteine, though medication effects vary considerably between individuals. The journey toward recovery from trichotillomania requires patience, persistence, and comprehensive support from both professional and personal networks. Support groups, whether in person or online, provide invaluable opportunities for individuals to connect with others who understand their experiences, share coping strategies, and maintain motivation during challenging periods. Family involvement in treatment can significantly improve outcomes, as loved ones learn to provide appropriate support without enabling harmful behaviors or creating additional stress. Recent advances in understanding trichotillomania have opened new avenues for research and treatment development. Researchers are investigating novel therapeutic approaches, including mindfulness-based interventions, dialectical behavior therapy techniques, and emerging pharmacological options. Additionally, technology-based interventions such as smartphone apps designed to track and interrupt hair-pulling behaviors show promise as adjunctive treatment tools. The stigma surrounding trichotillomania remains a significant barrier to seeking help, with many individuals suffering in silence for years before receiving appropriate treatment. Public awareness campaigns and educational initiatives play crucial roles in reducing stigma, promoting understanding, and encouraging individuals to seek professional help. Mental health professionals, educators, and community leaders must work together to create environments where people feel safe discussing their struggles and accessing needed resources. Looking toward the future, continued research into the neurobiological underpinnings of trichotillomania promises to yield more targeted and effective treatments. Advances in neuroimaging technology, genetic research, and personalized medicine approaches may eventually allow for more precise diagnostic methods and individualized treatment plans. Additionally, increased awareness and understanding of the condition among healthcare providers, educators, and the general public will likely lead to earlier identification and intervention, potentially preventing the development of severe symptoms and associated complications. Ultimately, trichotillomania represents a complex interplay of biological, psychological, and social factors that require comprehensive, compassionate treatment approaches. While the condition can be challenging to manage, with appropriate support and evidence-based interventions, many individuals achieve significant improvement in their symptoms and quality of life. The key lies in recognizing trichotillomania as a legitimate medical condition deserving of the same attention, resources, and understanding afforded to other mental health disorders, fostering an environment where affected individuals can seek help without fear of judgment or discrimination.